Hello and welcome back to TiCME, Time Critical Medical Education. I'm Dr. Nick Taylor and I'm an emergency physician and Director of Training based in Canberra. Today's talk is an important one I think at the moment, and it is a talk about the distinction both in the geometry and the physics, but also the technique differences between the Glidescope and the macintosh blade. I think what's happening in my experience is people are trying to use some of their old direct Mac technique when they're using the Glidescope, and I think that's led to a few difficulties. I personally think that the hyperangulated video laryngoscopes are saving lives. I think it's really important to understand why they're saving lives, and then you can choose which device to use at what time for what patient. It's not just me, there's a lot of evidence out there showing that video laryngoscopy is better than direct laryngoscopy in most situations. This is the most recent article I could find from Crit Care Medicine only a month or two ago, and it showed that all of the unsuccessful direct attempts were intubated with the Glidescope, and 82% of those on the first attempt. There was 0 esophageal intubations with the Glidescope, but 7% with the direct laryngoscopy technique. There are lots more showing very similar numbers. I'm going to start by just pointing out some of the very obvious anatomical things you need to know, but also some of the angles that are important when we're intubating a patient. This is going to be the really simple diagram that I use to explain most of the concepts, and we're going to really simply label the anatomy: chords, the epiglottis, the esophagus, the nasopharynx, and the trachea. Now, we have got very good vision, humans, and we can do lots of things, but one thing we can't do is see around corners. And it's clear from looking at this sagittal view that the angle between the chords and the mouth is essentially 90 degrees. Unfortunately, the usual way to look around corners, such as a submariner's periscope, doesn't really fit in the mouth very well. So what do we normally do to try and see around that right angle? Well, firstly, it's all about position, isn't it? We need to lift the chin with some jaw thrust and also get forward flexion by putting the pillow or the rolled up towel behind the head or shoulders. Secondly, we extend the neck, and that helps move that chin and change that angle as well. And thirdly, when we go to put the device in the mouth, it's really important to open that mouth up wide. So once we're positioned, you can see we've made a lot of difference to that initial angle without even putting a device in. So at this point, it's usually time to get the standard direct laryngoscope and the macintosh blade. Now you can see that it's shaped to conform to that curvature of the mouth that we've created with our position. And so what we're going to do is place it into the vallecula, and that's going to help us straighten out that field of view finally. So you can gently squash the soft tissues and move the tongue out of the way to help straighten out that line. But the final thing you need to do is lift the epiglottis, which then clears your vision away and you can see the chords. And once you've achieved that, the tube should be able to pass straight through the chords and into the trachea where you want it to be. Now, it should be also known that there's video devices with exactly the same geometry as the Mac blade. We have a version that is made by Glidescope, but there's lots of others. Now, the advantage that these have, if you're unable to completely straighten out those angles so that you can see the chords, well, a video Mac will stop you having to make those angles completely straight. So, in fact, they also have a camera with a wide angle lens on it, so you can actually get a better field of view. And you'll see that the curvature of the tube naturally, or your bougie, is designed so it actually matches that of your Mac blade and of the structures in the mouth. So if you do struggle to get a complete view, like you're getting a grade 2 or 3 view with a standard Mac blade, a video Mac blade will probably allow you to see, and the tube will probably pass along those natural curves to go into the larynx. But what if you have got an anterior larynx, or you've got a short neck? I like using the 3-3-2 rule to try and assess for these before I start. I think everyone should get in the habit of using that. What happens if you've got a small chin? Well, as you can see, what happens is the angle of approach suddenly gets much steeper. And so you've got much more work to do with a standard blade and positioning than you do normally. Also, what happens if you can't do any of that positional work to straighten out the angle? And the commonest reason in ED is probably a trauma patient in a hard collar, although maybe not for long. But I think we'll be still doing manual inline immobilization for quite some time. But also ankylosing spondylitis, rheumatoid arthritis, people with neck conditions where they can't extend their neck are going to have a more difficult airway. Well, I think in those situations, it's time to bring in one of the hyperangulated video laryngoscopes, such as the Glidescope. And you can see when it's put in the mouth, without any positioning, its natural curve follows around into the vallecula. So being able to see is terrific, but obviously the point of intubation is putting the tube through the cords. So the important thing, and probably a disadvantage of the video laryngoscopes, is you have to have a stylet that's relatively rigid and has the same curvature on it as the Glidescope video laryngoscope blade. So to state the obvious, the geometry differences between these devices means that you need to make a straight line or very close to it to be able to see the cords with a macintosh blade. And this can be anatomically or pathologically impossible. But if you can see the cords, you usually can put the tube straight in. Now the Glidescope can see around corners like a periscope, but seeing the cords is only the first bit, because then you have to try and manipulate a tube around that corner, and that can be the big challenge. So we've talked about the differences between the geometry and how you might use these devices. Now we're going to specifically go through each of the devices with tips for their use. Firstly, with both devices, never forget yourself or an assistant giving laryngeal pressure, which helps to move an anterior larynx posteriorly into your field of view. Remember that one of the advantages with the video scopes is the manipulator can look at the screen and adjust what they're doing to improve the view. Remember, don't forget to ask someone to pull that chin down and open up the mouth when you start to help you get the blade in, but also to increase your angles for making that field of view as wide as possible. Now to move on to direct laryngoscopy. The first thing you need to do is position your patient. I think you should hold the laryngoscope at the junction of the blade and the handle, and I like to try and just hold between my thumb and index and middle fingers so I'm not gripping too hard. You should enter the mouth with the handle initially parallel to the patient's body, and then gently sweep the tongue as you enter the mouth. You don't need to do a massive sweep movement. I find it's not usually successful anyway. You then apply gently increasing upwards force with the handle, and the handle's now pointing diagonally upwards towards the ceiling as you progress around. You should identify, hopefully, and then lift up the epiglottis with that force going along the line of the handle with the blade tip in the vallecula. Now specifically, it's important to come in with your tube from the side. Otherwise your hand and the tube blocks your field of view. Try and keep your hand low so that the tube is starting at a position where it's almost below the cord, so it can come up with its natural curve through the cords. And the other important tip, that if you come in from the side and you rotate anti-clockwise, you'll find the tip will just pop up anteriorly, exactly where you want it to be. Other tips are, if your bevel is facing so that the outlet is pointing upwards, if you strike the arytenoid cartilages, you will find that tube is more likely to bounce off and down into the esophagus. If you rotate the tube so that the outlet is facing downwards, you're more likely to strike the arytenoids and bounce up through the cords. Now, to improve your lever advantage, hold the tube close to its end. Commonly, people hold it in the middle or even closer down, which needs then a forearm and wrist, even shoulder movement to do any subtle rotation manipulation. If you're holding it right at the end, even just using thumb and forefinger rotation will give you a significant amount of change in the tip's position anteriorly. So hold it at its end gently. Remember that you should be pulling along the handle of your laryngoscope to lift that epiglottis up and out of the way. You don't want to be levering and breaking teeth. Okay, let's move on to the Glidescope or video laryngoscope technique. Now, firstly, look at the patient. Look at the patient's mouth and put the Glidescope blade in the mouth, in the midline, and advance it gently along the tongue until you have cleared the tongue. At this point, you can look at the screen and gently advance until you see the epiglottis. Once you have got the Glidescope in the vallecula and you can see the cords, look at the mouth again and put your tube with the stylet in very gently, again around the corner under direct vision until you clear the tongue. Then you look at the screen again and advance the tube through the cords. Specific tips for the Glidescope. Make sure you have suctioned really well. One of the disadvantages is the Yanker suckers don't have the same curve. I would really like the companies to make a hyperangulated sucker so that you can suction directly off the camera. Remember, if there is blood or mucus covering your lens, you will not see anything but blood or mucus. Remember the difference with the Glidescope. The blade goes straight down the middle or a bit to the left, and the tube goes vertically straight down the middle as well. It is not coming in from the side this time. If you can't see when you first put the Glidescope in and you've progressed around the corner, Corder et al. In 2012 suggested the very first thing you should do is ask someone to give you some jaw thrusts, and that improves the view in the majority of cases. Sometimes once you're in the vallecula, a tiny bit of gentle leverage with the Glidescope, so not pulling up and hard along the handle, will just move things a little bit to give you a better view of the larynx. Be gentle when you do this. It's really important with the Glidescope that you don't put the blade in too deeply. Okay, if you've got the blade in too deep, now remember the Glidescope, disadvantage again, cannot see the last 1 to 2 centimeters of the blade. So sometimes you might actually be over the epiglottis. If you've got the tube in so that you can see the tip of the tube, remember it will now be on the camera of the Glidescope, and you're trying to move it anteriorly. The closer you are to the cords when you try and move it up and anteriorly, the more angle you've got to adjust the position to get it in. If you withdraw your Glidescope and withdraw your tube, moving that tube up so that it progresses into the cords requires much less of an angle change, so you're not having to apply any force. Remember with the Glidescope that when you are getting close to the cords, you have to withdraw the stylet. Now the Glidescope's got that special blue plastic handle on the stylet that's designed so your thumb is on top of it to start with, and then your thumb slips underneath to push up to withdraw. If you were to keep it in and try and progress, that rigid curve will hit the anterior wall of trachea or damage the structures around there. So make sure you withdraw it. Now, here's some important safety tips I want to tell you about the Glidescope. There are some reports in the literature of damage to the pharynx from the Glidescope technique, and I think I know why after 1 or 2 episodes. Firstly, if you can't see any recognizable anatomy with the Glidescope, you have probably veered off the midline. If you see in this picture I've taken here on a model, you could be looking at the lateral pharyngeal structures. Do not lever from this position, because what happens is, with the Glidescope and its hyperangulated blade, if you lever too hard and you're in the wrong spot, you're putting all of that force through a very small and often sort of sharp surface area. So it's possible, with a great deal of force and all of it being applied to the tip, you could cause damage to the pharynx. If you look at a Mac blade instead when you lever, there is far more surface area being applied even if you do lever, and so the chances of damage, I think, is less. Very importantly also, you are using a very rigid stylet. The tube is relatively sharp on its beveled end, so if you are progressing firmly with this rigid stylet, you can force the tube out through the wall of the pharynx. So you should never advance the ETT unless you are watching the tip. It's very important with video laryngoscopes that you are seeing the tip of your tube at all times. So in summary of a video laryngoscope versus a direct with macintosh blade, ask yourself first when you assess your patient, what is it that makes this a difficult airway? If it's blood and muck, or if it's someone who's going to have lots of secretions, for example, you might find that a Mac blade and direct suction is going to be your friend. I think that for someone, for example, with pulmonary edema or ARDS, I'm going to use a macintosh blade because I need direct suction power and I don't want my lens covered immediately. But if it's neck positioning, such as described with the hard collar, or a person with a high or anterior larynx or a small chin, then the hyperangulated geometry of a video laryngoscope is going to give you the advantage you need in order to see the cords and successfully intubate the patient. Thanks very much for listening and watching, and I hope I get lots of comments and questions from you all afterwards.